Hey, Duke fam. For those of you who don't know me, I don't think I've met like half the intern class yet. My name is Seabass, like the fish. The purpose of the following two videos are first and foremost to give me an opportunity to experiment with something that I've been really interested in doing since I got here, which is the notion of flipping some of the formal didactics that we get as house staff. So with that, I think a couple of quick logistical comments on the two short Chalk Talk videos. The first is that I've tried to highlight in red font on my schema opportunities that I've employed mnemonics. I'm a huge fan of mnemonics. I know that they're not for everyone, but briefly, the two mnemonics that I relied upon heavily for this talk are one, the Duchess, or capital D-O-O-C-H for douche, which I use as a modified differential diagnosis for shock. The douche actually systematically allows you to remember all the different ways in which you can have decreased effective arterial volume. My wife is super into reality TV, and I think on one of the many Housewives shows there is a character named the Duchess. So that's where I came up with the Duchess. The second red sort of acronym mnemonic that I employ in this diagnostic schema is going to be Versace Tiger. So for those of you who are familiar with the international rap group Migos, you'll be familiar with their breakout hit, Versace. Incredible listen, highly recommend. Couldn't say more dope things about it. But if you employ V for Versace and then Tiger in the music video, there's a moment in which I think it's Offset, but maybe it's one of the other guys, has like a tiger like on a leash. Then VTIG or Versace Tiger can be used to remember the different types of intra-renal kidney injury. Last but not least, a rebranding of sorts. I, as an intern and generally as a medical student, didn't really take a liking to when attendings would want to dole out clinical pearls to me. I know that Ariana Grande is a fan of the pearl. I know that there is a Pokemon Pearl video game that was released in the mid-aughts. And I know that there's like a 90s band that my wife sometimes listened to that's named Pearl Jam. But for all intents and purposes, I could never really understand why a pearl would be useful to me as like an object. And for that reason, I'd like to rebrand clinical pearls. So for my talk, when there's a moment where I think there's a particular concept of high yield note, I refer to it as a clinical crepe, because a crepe is a tasty snack that everyone can enjoy. With that, let's segue into my two-part video series on a diagnostic schema for AKI. All right, let's pop off. So, for this particular schema, I use large buckets that we were taught in medical school. Namely, you're going to have pre, intra, and then post as the core buckets to frame your thinking about etiologies that can cause AKI. Unlike a lot of the stuff we learn in medical school, I think this is actually a good initial framework to then substructure your thinking. AKI, very briefly, we're going to define as simply a rise in serum creatinine from a patient's baseline or a decrease in urine output, or both. I think it's important to note here one conceptual notion, which is that AKI was formally defined in the KDIGO World Federation international meetings or whatever by a bunch of researchers with the idea in mind that we needed to have formal definitions of AKI so that moving forward in the literature, things were standardized. We'll come back to this concept again later, but again, AKI defined by researchers. Clinically, we're just going to focus on increase in serum creatinine or decrease in urine output. So if we move on and then go to these 3 core buckets, I like to then superimpose a mechanistic approach for my sub-buckets. So when I'm Marie Kondoing different mechanisms of insult to the kidney, I will place them, in a sense, in these geographic big headings: post, intra, and then pre. So with that, I'd like to rearrange the order. Instead of us going from left to right, I like to resequence this to go in an order simplest to most complicated, which means that we're going to start over here in the post column. Really 2 ways that you can injure the kidney from the perspective of post-renal injury. Post-renal, conceptually, what this refers to as a straight-up plumbing problem, a blockage. One of the places that you could imagine a blockage to occur is at the bladder neck, or basically at the outlet, the convergence point between where the bladder will empty into the urethra. I won't give an exhaustive list of ways in which that you could obstruct the bladder neck. For those of us who have been at the VA, we know that BPH is a huge one that we have to basically always consider in the back of our minds. 2 other examples I think that are important to mention here are a neurogenic bladder for any of our patients that suffer from a spinal cord injury, and then anticholinergic meds, which can also interrupt the ability of the bladder neck to do its thing. Second geographic way that you could have interference with the plumbing and that could lead to a backup of urine that damages the kidney is urinal obstruction. Now, here's the first clinical crepe that I want to introduce, which is that classically, the only way you're going to get an AKI from urinal obstruction is either bilateral urinal obstruction or unilateral urinal obstruction in a single kidney. 3 cases here that we might think of ways that you plug up the ureter could be from within, so nephrolithiasis, or on the outside, so bulky lymphadenopathy from whatever cause, or an actual tumor from a malignancy could pinch off the ureter from the outside. That's it. That is post-renal obstruction. That is the entire column. Let's move on. Let's go over here to the left to this column, the pre-renal category. The first thing that I want to do is talk about and define a concept known as effective arterial volume. And this is something that I wasn't really familiar with until like the end of intern year. And so I think it's a good point for us to sort of stick on for a second. I like to define effective arterial volume as the fraction of the extracellular fluid that's found within the arterial circulation and accordingly is responsible for perfusing end organs. So effective arterial volume, or EAV for short, is the stuff that's perfusing the organs of our body. This is conceptually distinct from an assessment of the patient's total body volume status. You can go up to a patient and pinch on their legs and say, wow, there's 3+ pitting edema, but that has oftentimes little or no correlation with what's happening in the intravascular space. And that's why this concept of EAV is so important. Decreased effective arterial volume can lead to normotensive ischemic kidney injury. And if this injury is fleeting or of a sort of not that big of a deal in the spectrum of big deals, then it can lead to a pre-renal injury on the kidney. In order to systematically explore etiologies of decreased EAV, I like to use the mnemonic the Duchess. This is a modified schema or etiology representation of things that can cause shock. But again, the conceptual distinction here is that These things can cause decreased EAV, which lead to normotensive ischemic kidney injury. You don't have to have a low systolic blood pressure to have this happen. Distributive etiologies are going to include sepsis as well as neurogenic causes or anaphylaxis. Oncotic etiologies of decreased EAV are going to include the nephrotic syndromes as well as our cirrhotic patients. Obstructive etiologies are going to include tamponade or a massive PE. Cardiogenic causes, the one that really comes to mind for me here is going to be congestive heart failure, like an exacerbation of heart failure. And then last but not least, hypovolemia. So hypovolemia from severe dehydration, from pooping a lot, or throwing up a lot, or bleeding, either overt bleeding that we see as a clinician or scary bleeding that's sort of ninja lurking in a space like the retroperitoneum. Using the mnemonic the Duchess can help us remember a systematic differential for things that can decrease the effective arterial volume. Moving right along, if we go to a change in local renal perfusion, as contrasted with global decreased EAV, there are certain things that can cause a change in local renal perfusion. I think 3 that I'm going to list, 2 of which I want you to absolutely have in your head at all times, and the third, which I just sort of have labeled as my 4th clinical crepe. So NSAIDs and then ACEs and ARBs are 2 common offenders that we see in both the inpatient and outpatient setting that can literally change the local renal perfusion and lead to a pre-renal injury. The third example is my 4th clinical crepe, which is the category of immunosuppressives called calcineurin inhibitors. Paradoxically, one of the classes of medications that we use to prevent rejection in our kidney transplant patients, namely calcineurin inhibitors, can actually sometimes cause decreased local renal perfusion. So I thought it would be an interesting addition to examples for this subcategory. Last but not least, in the pre-renal column, we have the sub-bucket of large vessel injury. Here, I think the number one culprit that will come to people's minds is renal artery stenosis. But other things can certainly be pinching off the renal artery. So abdominal compartment syndrome is one that I like to think of. VTE is another. And then last but not least, a dissection. If you have a dissection that extends to the renal artery, this can lead to a pre-renal injury. That's it for the first video. We've tackled core examples of post-renal injury and the corresponding 2 sub-buckets. And then we've tackled the pre-renal column with the 3 main sub-buckets being decreased effective arterial volume, a change in local renal perfusion, and then injury as sort of localized to the large vessel or the renal artery itself. In the next video, I'm going to tackle the most complicated of the 3 columns, which is intra-renal injury.